Hi. Hello. Hey.
Somehow it got dropped off. I don't know why.
What was that?
Somehow it got dropped off. Like
Oh.
my dropped out. Like I went too. Like, okay.
I hope everyone's okay. I'm going to record this so that for folks who can't join us, I'm going to post it.
Oh.
Hi. Hello, everybody. I see some new faces. Hello, Everett. You're walking somewhere?
Walking home.
Okay. And hey, Rachel, how are you?
How are you?
Hey, I'm good. Thank you. Good. Well, I was very happy to see all the good grades on the quizzes. Definitely the discussion posts were great as well. So definitely happy to do that. So anybody want to, before we jump in, does anybody want to give me any feedback on last week? How did it end up? Was it a little easier than you thought, the quiz, or was it challenging? Was the book helpful? Were the videos helpful?
Book videos were helpful. The test was easier than initially thought it would be.
Oh yeah? Good. Uh-huh.
The book was actually really helpful. At the end of the chapter, it's like a chapter review, and it like breaks down all the main points. And so I had reviewed that like right before starting the quiz, and I thought that would have like that hit all the key points that were on the quiz.
Good. Yeah. Good. Were the videos helpful?
They were.
Good.
And in terms of going back to the quiz, I think there were some questions that at least I kept like overthinking. And so just needing to be mindful about that and not trying to figure out something that's actually not there.
Right. And you get a little too worried, overly worried and stuff. Good. All right. So was everyone able to get through the videos this week and the chapter this week? Great. So again, I'm going to apologize for the corny videos. I know that some of them are kind of silly. I don't know that you got to Grandpa yet. I think that maybe is next time. But definitely was it Amy? Was that the healthcare person? Actually, I really like those videos because they're really educational, I thought. So
Yeah. I have the grandma with the knee bundling.
Oh, okay. I think Grandpa's next time then. Yeah. Great. Well, why don't we, what I was hoping that we could do is kind of just jump into the material. And again, this week is also similar to last week in that we're not going to do any kind of math problems or any of the finance related work yet. We're just going to talk concepts and some of a lot of the economic concepts. The thing that's a bit more challenging this week that we're going to start talking about sort of the incentives for some of the different reimbursement structures and sort of compare and contrast a little bit. So it's important that you can understand the differences of them and sort of the impact of some of these reimbursements in the marketplace and how they came about, what they were intended for, and maybe what's working and what's not working, right? So, okay, can everybody hear me okay? Okay, good, because I was hearing a little background noise. So if you guys do hear background noise, you can mute it and then, just pop in when you need to. Okay, so why don't we start with, let's see here, for my notes. We'll start with just the basics of the insurance, basic insurance, sort of like the idea of pooling of losses. And I think, hopefully everyone got that one. It's really, just a matter of the probability and cost, well, actually, when we pool our losses together, obviously, then it will allow us to, have a better chance of being able to cover it, right? So I think there was a great video that was on the website about that. It was very simple, but I think it was very powerful, the video about pooling of losses. And I think, there were like 4 different areas when we're talking about insurance: pooling of losses, payment only for random losses, risk transfer, and indemnification. And again, pretty simple. Risk transfer is really just transferring the risk from an insured to an insurer, right? The reimbursement payment for random losses is really just one of the concepts of saying insurance is based on the premise that only losses will occur that are unforeseen or unexpected, right, and a result of chance. Obviously, if we knew they were coming, we could prepare for them, right? And then we had indemnification, obviously, which is really just reimbursing to an insured if there is a loss. It actually occurs. Okay? So I think that's probably pretty self-explanatory. So adverse selection was a concept that was introduced in the book. Does anybody able to kind of describe what adverse selection is? Anybody want to take a stab at that? If not, that's okay.
I can try and take a stab at it.
Sure.
Adverse selection is basically, the whole concept of having a pool is so that you can spread the risk, right? With adverse selection, I think that concept is referring to a lot of individuals that are utilizing the healthcare. So it could be, maybe elder individuals that need to go for visits, or individuals with conditions that will be utilizing care. So if those individuals are the only individuals signing up for the insurance, then and you don't have enough people that wouldn't utilize the insurance as much signing up for it, then I guess that's referred to as adverse selection. Is that correct?
Right. No, that's a good explanation. And the way I kind of like to think about it, it's like a mix. Like you want your insurance pool to have a mix of, probability, right? You don't want the probability to be too high that everyone in your pool is going to actually need insurance. You want there to be a good mix of those who need it and those who don't use it. So when you have too many in your pool that actually are potentially going to use insurance, then you're weighting your pool toward the likelihood of an event versus having it weighted evenly, right? So that's right. So I think, and then we move on to moral hazard, which is also a concept in insurance. Anyone want to try that one?
When people take advantage of the system and say, for example, if like a grocery store, not necessarily in health, but if somebody has insurance coverage for their grocery store, and then this happened in East Oakland a lot. So they would have grocery store owners would be like setting their own stores on fire so they can claim the arson part of their insurance coverage, so they can use that to rebuild their grocery store or whatever. Or in the sense of in healthcare, if somebody is purposely extending their stay at the hospital, not necessarily because they need to be inpatient, but because they don't have any other places to stay, not necessarily purposely, but they don't have any other options to go somewhere to live, like some of our unfortunate patients.
Yeah, exactly. The example that I sometimes use is like if somebody takes you to dinner and they offer to pay for your dinner, does that mean that you order like 5 times more than you would if you were paying for it yourself? That's rude, right? So I think, it's a kind of a similar concept. Like, so you're not actually paying for your insurance, everything you use in your health insurance yourself. You're paying an insurance agency through a premium. But so does that mean that you can take any service you want because somebody else is paying for it? That actually adds more cost to the system when we do that. And that's, I think, one of the points in the videos, right? Is that one of the reasons that we have such a high cost of healthcare in the United States is because people are sort of used to, going out and getting more services than they really need. That's sort of what we're trained to do almost, right? And so that really puts a big burden on our healthcare system. So this is quite a big deal, this whole moral hazard issue. Okay, so let's keep going. So let's see, let's talk next about the types of insurance, okay? So we've got, we're moving kind of into the third party and private payers, okay? So a large proportion of the health services industry receives its revenues directly from insurers, not from users, right? That's the same, that's sort of what we just talked about. So, it creates a very odd dynamic when you have a market, because it's basically a market, right? Where you have consumers of the marketplace who aren't actually paying for the goods. It creates a very artificial type of marketplace. And that's what's so, I guess, awkward about our healthcare in the United States is we do have this very awkward relationship where it's not a direct relationship between those who are paying for the care, those who are providing the care, and those who are actually taking advantage of the care. It's kind of like that's what, creates this third party payer system, right? Because you have different players involved, right? And so I think that, it creates sort of a disincentive, as we said, for keeping costs down, right? And so I think that is where, a lot of these changes in healthcare and healthcare reform started from, because of the fact that the system is inherently flawed, right? In a way, right? It's just not set up for success because of the way that it's set up. So a lot of new things started, right? People were trying to figure it out. Well, what can we do? What can we do to fix this system? And they started kind of like a parent who's a new parent, right? You have a kid for the first time, you're super overprotective, right? Oh my God, we can't let the kid sleep in their own room. We have to watch them every second. So that's kind of what we started with first, was sort of this managed care idea, where we're going to manage, all the, all the patient's care. We're going to tell them who their doctor is. We're going to tell them, how much service they can have, and if they can or cannot have service. We're not going to let them go outside of our network. It's extremely controlling, right? That was sort of the first thing, and that's where we have the term health maintenance organization, HMO. That was sort of that first idea of that. And it was all about limiting the utilization of healthcare services, right? And then, we moved into, kind of morphed into a PPO, which is a little bit of a hybrid. The PPO, do you guys know what a PPO stands for?
I wrote it down in my notes.
Okay, yeah. And I'm going to look too. Okay, wait, because I don't trust myself. It's a preferred provider organization. Okay. And then in that model, they're starting to open up a little bit. Like, okay, maybe this is your second kid. You're not quite as, controlling with your second kid. You're letting the patient, go out and select their own doctor. You're not going to provide a gatekeeper doctor. They might be able to go out and find a different doctor if they need one. They're opening up the network, so you don't have to be in network. You can be out of network, right? If you really like somebody. But I think, although that did open up and wasn't quite as controlling, what they also found is that reducing costs in the system isn't just about reducing utilization, right? It has to be more than that. It also includes things like, hey, are we doing a good job? Are we actually helping people? Are they getting better? Are we asking people to take care of problems on the front end instead of waiting until something's chronic? So there's this idea of, improving the quality of care and reducing cost, right? So that the whole experience is better. And I think there's also the ideas of not treating patients like little kids. Involve them in the decision process, involve them in the payment process, so that then they have more skin in the game, right? So that's kind of what you started seeing next, is like you had more ideas around how we could provide services and how the consumer could pay for the services. So now you're getting co-pays, and you're getting co-insurance, and you're getting a much broader array of plans that you can choose from. And so the models today, aren't nearly as limited as they used to be. Now often you have a very broad continuum of different options in healthcare, and they can be very broad within your own health insurance agency, right? You can pick a broad array of things, right? So that was sort of like the next sort of area. Now we have a lot of insurance providers that have a lot of different options. And then, then the healthcare reform came along, right? And that healthcare reform is really trying to address some really basic problems, right? So they were looking for access. They were trying to address access to healthcare, because not everybody had healthcare. They were really trying to focus on cost reduction, and they were really trying to make sure that the care itself was good quality care. So you'll hear that, right? Access, costs, and quality. Right? You've heard those three things. So just remember those three things, okay? Maybe make a little acronym, right, for that. But that's those really important things. So can anybody, share what some of the healthcare reform introduced? What were some of the key things that it was trying to address?
Okay, I think I can weigh in on this one. Can you all hear me okay?
Speak up a little bit more.
So can you all hear me okay? What about
Yeah.
now?
Mm-hmm.
Okay. And can you ask the question again?
Yeah. So what was healthcare reform? What were some of the key ideas that healthcare reform wanted to change? Or what were the key focus areas of healthcare reform?
Yeah, one of the biggest things they wanted to address was getting more people insured. And as far as the healthcare system, it wanted to create pretty much almost like a community of healthcare providers working together to expand out to different areas of the community, or wherever the healthcare system is.
Right. And I think what you're describing is the outcome, right, of introducing the healthcare reform concepts. And, there were lots of different models after healthcare reform got introduced that where there was more collaboration, there was more, sort of just, what's the word I'm looking at? Creativity on how to deliver healthcare, right? So that was definitely one of the things that came out of it. But in terms of the actual motivation around healthcare reform, let's talk about some of the specific things that healthcare reform was hoping to do, okay? Because I think that's important for you to be aware of. So again, we talked about access, right? And so, in the old model, there were lots of bans on pre-existing conditions, right? So if you had a pre-existing condition, then you couldn't get healthcare. right? Because they wouldn't take you. So that was one of the things that the healthcare reform abolished, right? There's no more bans for pre-existing conditions. Another one was the young adults. So in the old model, if you were a young adult, you were out on your own and you had to deal with healthcare yourself. Whereas the healthcare reform allowed you to stay on your parents' healthcare longer, right? So it covered all those younger folks, right, who often didn't think they needed healthcare, right?
Didn't that vary depending on some companies? Because some companies did have healthcare for kids up to 26 or 20.
Yeah, right. Definitely there were exceptions, no doubt, but in general, most didn't, right? And so that's what healthcare reform was trying to increase the access to healthcare for as many as possible, right? So, and then, there were no appeals for denials of payment. So if a healthcare claim was denied, that was it. You really couldn't do anything about it. So healthcare reform now is, mandating that there is an appeal process. If somebody denies your claim, you absolutely can appeal. And then, last but not least, they didn't allow an insurance company just to cancel you. So if you had, you developed a condition, and the insurance company felt like you were too costly for them, they could just cancel you. So they no longer can do that. So those are all things that have been, brought about through healthcare reform that helps the access portion of healthcare. And in terms of cost, so there's some things that they've introduced, which are transparency of the premiums and the increases that you get when you have insurance. They make sure that the rates that are charged are consistent around the geography and the age. So they're not going to, have various rates all over the place for the same age or the same location. They made sure that lifetime coverage is available for most benefits. In the past, lifetime coverage wasn't available, and so you would max out. Like if you spent your total allotted amount for something, then you wouldn't be able to use that anymore. So that was changed. And then there's a requirement about how much of the premium you spend has to go towards direct care. So 80% has to go toward direct care. It can't go through administration costs. So those are what I would consider cost-related items. And then last but not least, the type of care. So now with healthcare reform, there are some essential benefits that have to be included in your healthcare. So you have to have prescription drugs, and there's a whole slew of things that they're requiring you to have. There's also the idea that preventative care is free. And that's a really big one, because obviously free preventative care will incentivize patients to go and get preventative care, which then will help them not come back. It will prevent chronic conditions and will make people healthier overall. So that was also a really important one. And then there are things like, emergency care can be obtained outside of your network. And, if you do need to select a primary doctor, you can do that, and it can be outside of your network. So some of those things. So that's healthcare reform. Now, I think as I said, sort of what happened when healthcare reform was introduced, there was the implication in the marketplace. So how do we introduce healthcare reform? We have to make some systemic changes, right? So they had to ensure that healthcare, there were new marketplaces for people to buy healthcare, right? So now that's something that was created as a result of this new healthcare reform. There is new patient-centered, what we call medical homes that focused on chronic care. And we made sure that the Medicaid was expanded to include adults that didn't have children as well. It wasn't just you know, for people that were getting Social Security that had children. So they expanded Medicare also. So these are some of the things that occurred because of healthcare reform. Okay. Now, I'm going to move on to health insurers. Okay. All right. So, okay. No, actually, let's talk about Medicare. Okay. So can anyone describe to me about the different parts of Medicare? There's a part A, B, C, and D. Anybody able to tell me what those are about?
Yeah, I can weigh in on this one too. So Medicare A covers hospital visits. Medicare B is more like ambulatory care, outpatient clinic.
Mm-hmm.
Medicare C is a combination of the two, A and B. Medicare D, which is the one that I'm more familiar with, is prescription pharmacy related.
Uh-huh. Good. That's right. And so Medicare C is basically, it allows people to use private insurance to get A and B. So the private insurance industry can offer Medicaid to clients or Medicare to patients, and they can pay for it through private insurance. So essentially, the private insurance marketplace wanted in on the Medicare, right? Because they wanted to be able to offer that to patients as well, right? So now, does anyone have an idea of what percentage of the U.S. healthcare marketplace is covered by Medicare? What do you think? Just give me an idea. What do you think? 5%, 10, 15, 20, 50?
About 20%.
About 20, yeah. It's about 17, but yeah, that's about, roughly 20%, right? It's about $50 million is what they're saying, right? So let's see here. And I'm going to go on to this one. All right, so I'm going to go into now the types of fees, okay, insurance reimbursements, because that's kind of like an area that we're definitely going to talk about in future chapters. So I want to make sure that we go over that. Okay, so I'm going to find it in my book here. Okay, so we've got the different types of reimbursement methodologies. Okay, so when I say reimbursement methodologies, so what do you think I mean by that? Does everyone understand what I mean by that? So basically, you have a patient who pays premiums to an insurer, like Anthem, and then Anthem has contracts with the provider, which is the hospital, right? And there are ways that the hospital, charges Anthem, right? And there's ways that the insurer charges the patient, right? So there's obviously money going in both directions, right? So what we're going to talk about is how insurance agencies reimburse providers. Okay, that's kind of what we're talking about now, right? And so there are these different methods called fee for service. Fee for service. Now there's like 3 different kinds of fee for service. One is called cost based. One is called charge based, and one is called prospective pay. So does anyone want to maybe tell me what you think those different fees are? how would you think about those differently? Does anybody work with these kind of fees in their job? I know some of you work for health insurance organizations, right?
Now, are you talking about more so like, like the co-pays, co-insurance?
Well, this is more about what the
Yeah, I guess not kind of
insurer is paying the hospital for, right?
Yeah, is the cost-based part where I think when one of the videos where they sort of had the different graphs, and if it's more for an institution, a hospital, say for example, if they incur more costs, then they would get reimbursed more?
Right, that's right. So basically if you said, hey, look, we're just gonna provide this emergency room service for you, and you just need to pay us what it costs to have the emergency room. Okay, I don't think that actually happens like that, but I'm just giving an example, right? So, so then, if the emergency room costs $10 million, that's what they get paid. If it costs $20 million, that's what they get paid, right? So that's one way of doing it. You could just say, based on the cost, you're gonna pay us what it costs. Charge-based then, anybody have an idea what charge-based is?
Isn't that traditionally made up by like a dentist? If you go to a dentist, they have the freedom to decide how much a procedure costs, and then you'll just have to pay them that much.
That's probably more like a prospective payment.
Oh.
I think it's related. So this basically, like if you have a menu of rates and they're fixed, right? Here's what it's cost for a tooth extraction. Here's what it costs for X, Y, and Z, and those don't change. So you get these different services, and here's what you get charged for each service, right? It's kind of like a menu, right?
That's the one where they have that charge master list or something?
Yes, that's right. The charge master, exactly. And then there's prospective pay, which is often by procedure or diagnosis, right? And so that means like you're coming in, we don't know what you need, but we took 5 x-rays and we draw your blood and we did, these other things. And so now you have to pay for these different procedures, right? That happened. So that's one way it could be, or there's also per day is another way. Sometimes you can get charged for a procedure. So if you're you go to the emergency room, and you're there for 10 hours, you get charged a per day rate. And then there's capitation, all right? So anybody know what capitation is? Yeah, not decapitation.
By head, so the number count of people who comes in.
Yeah.
For service.
Right, exactly. Right. So this is an interesting one, right? So it's basically if we refer to this in my organization as you want to buy a bed, right? So if you have, well, it's actually not quite like that, but if you have 10 people that you're serving in your emergency room, and you have to pay a charge for each of those people, whether they use it or not, you're paying a charge, right? So it's basically like setting a unit limit or negotiating on a unit number and paying based on that unit number. So if as an insurance provider, maybe I have 200 patients. So I'm going to ask the hospital to see these 200 patients over a year. I'm going to negotiate with the hospital how much to pay them for each patient, for taking care of each patient. And then it's up to the hospital to figure out how best to take care of them. But I'm just going to pay them this fee, whatever the fee is we negotiated, I'm going to pay that. So it's not based on the actual cost. It's not based on the procedures. It's not based on what services they get. It's based on this negotiated rate. So it's up to the hospital to figure out then how to make sure they don't spend more in costs than they're getting by this negotiated rate. Okay, so this one requires a lot of thinking about, like, well, what does the average patient need in terms of services, and how are there things I can do to make it so the patient doesn't come in as much, you know? So each of these models that we described has a different result when it comes to the hospital or the provider and how they may react to these types of structures, right? So for instance, if I am being reimbursed on cost, okay, so what kind of negative behavior may that incent me to do if I'm always, based on cost? Can you imagine?
You're sort of more biased. It's like you're trying to charge people more.
So you probably add more cost, right? Mm-hmm. You'd add more cost because you get more revenue. Like, there's no incentive not to add more cost. There's probably incentive to add more cost, right?
That's like the example that was given in the book of having someone stay longer in the facility so that they could max out the amount that they would get at that time, versus if they spend less days or more days, they would try to max that out. Right.
In that example, I think that was probably more of a per day rate. So if prospective payment per day, if you have a rate for someone, coming in per day, and therefore there's an incentive to keep them longer, right? Because you're getting paid more. And, with the prospective payment, since it's not based on actual cost, therefore you probably have a little margin in there. So if you have them stay more days, you get more margin. You make more in the end, right? The charge-based procedure is where, you want somebody, the negative behavior there, right, would be, let's make sure that we can think of all the different charges that we're going to throw at this person, right? Or have them come back more. Keep having them come back. If they're sick, let's bring them back in a week, bring them back in 2 weeks, right? And then we'll just charge more for that individual because we can keep charging, right? So that doesn't incent us to reduce utilization, does it? Right? That incents providers to increase patient utilization, not decrease patient utilization. And then the prospective payment incents us to provide more, procedures, right? Have them stay longer, more days. Have them go take some more X-rays. Go have them, take some more tests, right? That would incent that kind of reaction, right? Now, what about capitation? Any idea what the capitation model would allow us to, what kind of negative behavior might that incent? So if you're getting paid a fixed amount, let's think about it. Like, let's say that
you wouldn't do procedures.
The quality of care is reduced because you don't necessarily feel like there's an incentive to provide the amount that you're going to be reimbursed. It's like, why am I going to provide so much care when I'm not going to be able to be compensated for, like, the number of staff members that I'm going to staff, but there's like no patients here.
Exactly. You know what this reminds me of is I used to have an au pair that came and lived with me. Mm-hmm. The things that I was supposed to do is I'm supposed to provide for the au pair, give them room and board, and give them a little stipend. But the idea was that they babysit my kids every once in a while. But there was always this incentive for the au pair to go out on Saturday night and have fun with her friends instead of watching my kids because she got her room and board. She got her stipend. It didn't matter. She didn't waste her Saturday night to watch my kids. That, right? It's like, you're already getting paid. you're supposed to be providing these services, but you'd rather, it's not going to change what you're getting paid. So might as well, not provide the services, right? So I think that is one of the things where the capitation model, there's an incentive for them to not see patients as much, right? And so that's the danger with that one. It's kind of the opposite, right? It's really very different than the other. Hi there. Hi, how are you? Welcome. So you can see how each of these really does incent different behavior, huh? You can really see how, you have to be really careful, right? Because, you can sort of like take advantage of the insurance company, right? Depending on what you decide to do. And so I think we often will see a lot of waste in the, in the provider world, right? So they're asking patients to take procedures that aren't necessary either, because that incents them to get paid more. So not only do you see that waste happening on the patient side, whereas I want to take more procedures, I want to do more because I'm not paying for it. You see it on the provider side because I'm going to make more revenue if I, ask people to take more tests that they don't need. So, it's really important when we understand how these reimbursements impact our healthcare marketplace, right? It's really there's a big impact there. Okay. So, and that's going to be on your quiz. So definitely think about that. I'm going to be asking you some questions about, this example. I'm going to give you an example and say what kind of fee structure is, would be incenting this bad behavior, right? So you need to be able to think about that. Okay. All right. So I think the last thing we have is the medical coding, right? Do any of you deal with medical coding? Like the codes, the medical codes, what are they called? The ICD codes? Anybody deal with that in their job?
I deal a lot with those. I do surgery scheduling, and so a lot of it has to do with ICD, which is like the diagnosis codes, and then CPT, which are the surgery procedure codes.
That's right. Now, do you work on the insurance side or the provider side? I work
on the provider side. So we have an authorization department where the provider basically, she tells me what kind of surgery it is. I submit the codes to our internal authorization department, and then they submit it to the insurance.
Okay. And do you ever try to figure out what is the best code to give them so you can get paid the most?
So not so much to get paid the most, because in my position, at least, I don't know, like I submit it. And then once I submit it, all I hear back is approved. So I don't necessarily know the fees that are associated with it. But I would say we do definitely depending on what it is, some codes, generally don't require authorization by the insurance. And so we more so play that game of okay, for whatever reason, we want to do surgery on this person this week because of staffing or availability or whatever, we're going to go ahead and submit this similar code that generally doesn't require authorization, as opposed to this other code that might be more applicable, but it might take 3 days to hear back from the insurance company.
Right. And so there's a lot of gamemanship that happens with these codes. And what's really interesting is that the insurance providers guard them very, very closely. I know that if you call the insurance provider and ask them to give you the CPT code or the IDC code for, something, they won't do it. So it becomes really hard, to actually figure out what code to share. But it is a little bit like the treasure trove, in the hospital world. And then there's a lot that revolves around those codes for sure. Excuse me. Okay. Now let's see here. Yeah, and I'm not going to go into tremendous detail about all the codes because I honestly don't know that that's as important. I think that I want to talk a little bit about the healthcare reform reimbursement methodologies. So, after we've gone through some of these reimbursements that we talked about, there have been different methodologies that have been introduced because of healthcare reform, because the methodologies we talked about, don't always incent good behavior, right? So there's definitely a lot of ideas around. So one of the videos you watched was about bundling. Do you guys remember that one? What did you think about that?
I thought it sounded like, on paper, I think it sounds like a good idea, where it's, you have this patient care team and they're all going to be involved in providing for the patient, and then they want to keep costs low because whatever, if they're getting paid X amount of dollars, if they can keep the cost low, they still get paid the same amount. But then I think it runs into the same problem of like quality of care. Are they going to order the exams, the tests, all of that stuff that they should do? Or are they going to say, okay, I'm going to just use my personal judgment and not order that because it's going to, make me more money and make the team more money?
But at the same time, that would hurt them in a way, though, because if they don't order enough tests, and if the patient comes back, then they get penalized for that. So I'm not.
So they're with these kind of new concepts, they're really trying to figure out how to reduce the gaming that's happening in the system, right? And they make them really complicated. So in a lot of respects, there's still a lot of work to do around finding the right solution that strikes a balance between good quality care, cost reduction, and negotiating appropriate rates, right? Because even Medicare, they come in and they negotiate very low rates, and many hospitals have to take these low rates. But then that also creates bad behavior in other areas, because then the hospitals have to charge more than they would for other patients, right? So they can get that mix of revenue that covers their costs. So, it is definitely a big challenge, right? When we look at healthcare overall and just the multitude of different challenges that are a result of it. But I think, the idea is they're trying to get creative with some of these concepts, some of these reimbursement methodologies. And so there are things that are introduced here in this chapter. One of the things is the value-based purchasing, right? Has anyone talk about that? Can anyone share with me what that's about? Somebody doesn't have their mute on, and we can hear sort of, I don't know where they are, but they're maybe in a hospital or so maybe you want to, there we go. Thank you. If you want to speak though, go ahead and unmute, but anyone know what value-based purchasing is? So it's basically for Medicare beneficiaries, and it's rewarding sort of more acute care hospitals and facilities based on their quality of care, and right. And so it's kind of unique. It's an approach for reimbursement that, as I said, rewards quality of care rather than quantity of care, right? So it's really focused on quality. But I'm sure it's extremely hard to measure, right? Then there's quality-based clinician compensation, okay? And these are in your book on page 63. There's a few of them here that are described. The shared savings programs, you can read these. And here's the new bundled payment model, which we had one of the videos based on that, right? Readmission reduction program, and hospital acquired conditions. So those are all sort of other methods that are being implemented and used to make sure that we are focusing on improved access, reduced costs, and improved quality of care, which is what the the healthcare reform was all about. So. So, Rachel, you enjoying your dinner? So that's, I think that's it. I know we've got about 7 minutes left. So that's sort of the content of the chapter. Does anybody have any other questions, or any questions about the assignment, or any follow-up questions around the chapter material?
For the assignment, did you want us to have certain formatting like APA? Do we need like a reference page?
I kind of I don't really require you to do a lot of quotes, right? However, if you do quotes, you have to use the APA format, and that includes paraphrasing. So that I'm really, it's really important for me to ensure that you're using your own voice, and when you're not, you need to be able to reference where you're getting your concept from. It's really important. So, but yeah, what I'm really hoping is to hear your own thoughts about it, comparing and contrasting what your director or your manager, what their thoughts were, how that relates to the article, what you think about it. I'm really just trying to see sort of like how the conversation's going and how you think it's relevant. So it's not really about a right answer or a wrong answer. It's just about the conversation and what ideas come out of it, right? So. Anybody have any other questions on the assignment or anything else?
Yeah, there's a group chat question that was posted.
There's a group chat? Okay. Oh, okay. Let's see. See if I can find that.
I can read it for you if you want.
Oh, okay. I don't know if I see it. Huh.
It's located at the bottom of your screen, right next to record. To the left of it, it's like a little chat thing. So if you click on that, it'll.
Oh, there it is. Okay, wait, I got it. Okay. Sorry, I'm in the library, so I can't talk, but I have a really quick question about the value-based model you mentioned. I remember reading in the article that we will be doing our assignment on mentioned MACRA. Is this the same thing? So is it the assignment in my class, or is it the assignment in a different class?
No, in your class, the article mentioned MACRA.
Oh, okay. The article, the one that we're reading for this this coming
Sunday. Yeah.
the same thing, because I remember reading that physicians get paid according to the quality of care they provide. I'll have to take a look at that, because I'm not sure that I remember that particular acronym in there, but it could very well be. So that would be nice, wouldn't it, if it's related?
So then you'll let us know?
So the MACRA, so you're just wondering what that is in the article? Is that your question, or if it is the same thing? Is that right? Yeah, I can definitely send you guys an email. Let me look at it. I'll look at it and just see what that is, and I'll send you an email kind of clarifying that, or through the announcements.
I do have a question about the assignment.
Yeah.
So I talked with my manager, and she's not able to give me like any financial numbers, but more so of the concept or how it can possibly influence the finances. But I do have a meeting scheduled with the director, and that's going to be next week.
Okay.
After the time is due for the project. So I guess like two questions here. Will you be okay with me submitting what I discussed with the manager? And will well, I guess there's really no second question, but because I still want to follow up with the director to get the insight about the finances as well.
Yeah, so I don't think that this assignment has to be about finance. I mean, great if your conversation goes there, that's fine, obviously. But I think, I don't want to presuppose that your manager, that's going to be their most important topic. But if you do have a meeting with your director and it's a finance person, then you might want to try to get some information about indirect costing and your budget, right? And how that's put together, because that's going to be something that you're going to have to do later on. So I don't know if it's sounds like it's a finance person or somebody that has some finance background. Is that right? That you'll be meeting with later?
I'll see. I'm not
okay.
Sure.
Because I have some questions that are in the assignment. If you look in the assignment for the budget and the indirect costing, there are very specific questions that you can ask the director. And hopefully then, it'll make that conversation a lot easier, right? About what exactly you're trying to get and what you're trying to understand from them. So was everybody successful in getting a manager or director to have a meeting with?
I think yesterday when I sent you the email, I had located my supervisor director of our program, but because we're at SF General, a lot of the funds that she gets, she mentioned it's not at the level of where a health executive would go. So I sort of gave her like a premise of what the article was about, like the different challenges, and she sort of was like, this isn't sort of within her job scope of handling the finances, and she felt kind of uncomfortable or felt like it wasn't a perfect fit for me. So she sort of directed me with a pharmacist who would be more in touch with the pharmaceutical costs, but time is very tight for this assignment. So I'm just trying to figure out how I want to, I guess, refine some of the questions I might ask her tomorrow. Maybe on the lines of more operational instead of financial questions, because it seems like it'll be too far-fetched to connect the two for her.
Yeah, no, I think what I would do is really just start out with saying, what are the challenges that you are dealing with in your job, right? What are the most important challenges that you deal with? And having a good conversation about that. And if she has or he has any ideas about what he could do to alleviate the challenges or things that he's already doing to mitigate the challenges, I think that would be really interesting for you to talk about. You can definitely then introduce the article and say, here are some, here's an article that we're reading in our course that has interviewed various leaders in the healthcare, and these are the types of things that the article points to that are, important for many healthcare leaders. Can you relate to any of these things? What do you think about these things? And, maybe the answer is, yeah, I don't really deal with those things, right? And that's fine. That's absolutely fine. But I think, just, interviewing them and asking them what kind of challenges they deal with. If the conversation goes to finance, great. If they have financial concerns or there are things they deal with in their job that are financial, that's fine. But if they don't, I wouldn't necessarily push it. I wouldn't expect that they need to be only speaking about financial things. I think it's just good that you're meeting them and you're having just general conversations with them, and you're hearing what it is that they're grappling with in their jobs, right? I think that will just be really, a nice conversation, and it just kind of brings the class to your workplace and your job, and thinking about it in a different way.
So it'll be more like sort of a informational interview with our leaders.
Exactly.
Okay.
Yeah, that's right.
That alleviates a lot of anxiety.
Oh, okay. Yeah, you don't want to have to interview them on, what the, what some complicated financial concept is. That would not be fun. No, that would not be fun. Yeah, so I think, and if maybe your question about the MACRA, MACRA, if that's getting you caught up in that, I wouldn't worry about that, because really what we're just trying to do is mostly try to hear from them. What are their challenges? And then, you can use the article for some fodder, right? Just to kind of have, here's what I found, that were these concepts. And then just, kind of just let the conversation go where it may. Yeah. I'm really looking for your own thinking about it, right? When you interview this person, what are your thoughts about the person, and what are they, do you imagine that some of the things that they're struggling with, were those things you may have thought about already? Were they new to you? Were they, expected when you heard about them? Are there ideas that you have that you could imagine that they could, are ways they could be dealt with? Are there any correlations to some of the material we've read so far or not? Maybe there are, maybe there aren't. So I just think, it's just really just trying to bring that in. Okay. Okay, well, thank you so much, everyone, for joining. And I look forward to seeing your assignments. And the quiz is coming up, and it's available on Saturday morning again. Hopefully that worked okay for everybody, that timing. Okay, great. And I would love feedback. So if you guys have suggestions, would love to hear it. So.
Is it possible to actually have the quizzes available from like Friday evening?
Possibly.
Because I think sometimes, at least for me, like my weekends get kind of hectic sometimes with stuff going on, especially on Saturdays running errands and stuff. But like on a Friday night, sometimes I have more time to buckle down and get those sort of things done.
Yeah, I was thinking about that actually when I set it up. So the only reason why I wanted to do Saturday was because I kind of divided up your discussion posts into 3 blocks, and the final discussion post was done on the Saturday, Sunday. And so I felt like I wanted to kind of keep it like the final stuff would happen in the Saturday, Sunday. But I also, if that's too challenging, everybody works a little differently. Some people do stuff on Sundays and that's the time they do it. Some people don't. So I don't want to open it up too wide because I do want people to take the test, in a similar time frame. But I think, Friday night might work. So I'll check with Peter and see if we can open that up Friday night. Okay, great. All right. Well, thank you, everyone. Have a great night.
You too. Thank you.
Okay. Bye.
Bye.
Bye.